Hello, my name is Jeremy Schmoyer, and I'm a second-year internal medicine resident at Verde Valley Medical Center, sponsored by Midwestern University. Today I'm going to be presenting a case presentation involving infarcts to the left middle and anterior cerebral arteries associated with cerebral T-wave inversion and Takotsubo cardiomyopathy. First off, why are CVAs important? In the United States, the annual incident rate of first-time CVA was noted to be 610,000, with recurrent CVAs being 185,000, estimating 795,000 cases per year. Cerebrovascular accidents are classified into two major categories, ischemic being approximately 80% of cases versus hemorrhagic. Acute EKG changes have a more well-known association with the subarachnoid hemorrhages, with these EKG changes consisting of ST segment elevation, QT prolongation, aberrant Q waves, and T wave changes. Ischemic CVAs rarely are shown to have EKG changes, but when they do occur, sometimes they are associated with cerebral T waves, which are defined as diffuse, large, upright peaked T waves or deep T wave inversions on EKG. The pathogenesis is not fully understood, but has been suggested to be a result of alterations in the autonomic nervous system driven by brain stimulation, with pathology potentially leading to LV dysfunction. In 2018, a retrospective study was conducted on 800 CVA patients, which 17 had cerebral T waves on EKG. Of the 17, only 3 reported to have LV ventricular dysfunction. This LV ventricular dysfunction can sometimes commonly be known as Takotsubo's cardiomyopathy or stress cardiomyopathy, which is a transient regional wall motion abnormality involving the left ventricular apex and mid-ventricle, but without evidence of obstructing coronary artery disease. So overall, acute cerebral vascular accidents complicated by cerebral T waves are uncommon, and the association with Takotsubo's cardiomyopathy is even rarer. The case being presented is of a 73-year-old right-handed Caucasian female who presented to the ED with complaints of right-sided weakness, numbness, and new-onset ataxia with delayed presentation due to her chronic paroxysmal numbness and tingling of her right arm, extending back for 2 years, with history of severe peripheral vascular disease with known occlusion of her left internal carotid artery and occluded left common iliac artery with a stent placed 4 years prior. In presentation, she had no chief complaints of chest pain or palpitations I wanted to mention at this time. Her initial vital signs were all unremarkable, with additional physical exam findings of no cranial nerve deficits, dysarthria, or dysphagia, but revealed a complete right hemiplegia without any loss of sensation. Additional lab workup were all unremarkable, especially her troponin of 0.04. I will talk about her EKG and MRI findings at a later time. However, the day after admission, the patient did receive an echocardiogram to rule out any cardiac source of emboli, which demonstrated akinesis of the apical septal left ventricular wall and cap, which led to a cardiac consultation and subsequently a left heart catheterization. Eventually, the patient was discharged to an inpatient rehab facility for further recovery of her right hemiplegia, tolerating all interventions throughout the hospital course with no complications, and instructions to continue Plavix, aspirin, atorvastatin, and home Coreg. On this slide, you can see a series of EKGs for the patient throughout her hospital course, with image A corresponding to an EKG from prior admission to the hospital. Image B shows the deep cerebral T waves in V2 to V5, and images C and D respectively performed on days 3 and 4, showing complete resolution of the deep cerebral T waves in V2 to V5. This slide demonstrates a series of images from the patient's MRI received during the hospital course. In these images, you can see that there are hyperdense lesions in the areas that correspond with the middle cerebral artery and the anterior cerebral artery. In addition, I wanted to mention that you can also see that the insular cortex was spared in this MRI, which I'll talk about later on in the discussion, the importance. The last imaging I have is from the left heart catheterization the patient received during her hospital course. During the left heart catheterization, she was found to have clear coronary arteries. However, on the venogram displayed a octopus appearance in the heart, which is pathognomonic for Takotsubo's cardiomyopathy. In discussion, a network consisting of the insular cortex, anterior cingulate gyrus, and amygdala may play an important role in the regulation of the central nervous system in relation to stress. The insular cortex supplied by the MCA has a variety of functions, including autonomic control of the cardiovascular system. Different studies showed that stimulation or downregulation can have different effects on the heart. A rat model demonstrated that the insular cortex can cause complete heart block when stimulated. A study using mice demonstrated that 9 of the 14 mice with permanent left MCA occlusion resulting in left insular cortex infarction actually led to elevation of neuroepinephrine. This damage resulted in significant LV dysfunction, while the LV dysfunction was not found when right insular cortex infarction was induced. Additional studies also demonstrated damage to this region may be associated with increased sympathetic tone, which could be the influencing factor in setting Takotsubo's cardiomyopathy. Of note, there are different studies that do not show these exact results. One listed at the bottom of the reference page was Stone, which showed 2 out of 3 infarcts of the right insular cortex resulting in cardiac dysfunction. In addition, Porter did cat models which showed that demonstrated reproducible T waves abnormalities with stimulation of the ventral hippocampus and medial nuclei. Another theory that's discussed is lateralization, which may be an important factor in this mechanism as well, where the left hemisphere has been found to be involved in more parasympathetic functions versus the right, which is more sympathetic. So large infarcts to the left may downgrade the parasympathetics, leading to overdrive of the right-sided sympathetic system, causing cardiac dysfunction. For our patient, she suffered an ischemic stroke involving the left MCA distribution. Interesting, she had no radiographic evidence of the left insular cortex being affected. So this leads to either prove that the lateralization may take more of effect in this case, or that the damage required to induce these events is not well visualized on current modalities, or can also support that a different area of the left-sided brain may have some cardiac control as well, leading to the Takotsubo's cardiomyopathy. In conclusion, this case emphasizes the importance of recognizing T-wave changes on EKG and thorough investigation of consequential heart failure in CVA patients with Takotsubo's cardiomyopathy, and EKG changes seem to be linked to left insular cortex injury or large left-sided cerebral hemisphere damage, causing an increase in catecholamine release. However, further studies may be useful in localizing additional brain regions that could be involved in EKG changes and subsequent heart failure, given that the areas above are not always affected when these complications present. In addition, considering the resolution of current imaging modalities and whether or not the damage can always be visualized using them. Attached are my references used throughout this presentation. Lastly, thank you for your time and listening to my presentation.